Sanjay Kumar. I'm respiratory consultant. I work in Colorado and Huddersfield NHS Foundation Trust. Well, on short notice yesterday, I was informed to do this talk for you, so I managed to put something together, and I hope this will be beneficial. On top of that, I would probably like, if you have any question, even how much silly it is, doesn't matter. We can do some interactive talk, and you can ask me a question that would be useful for you and to understand this complex situation. So what my objective would be today to just introduce you this complex topic, which is fairly new. COVID came in 2019 in November, December time, and probably not all of you may have worked during COVID. You might be in medical school if your foundation year 2, but still may be involved in some of the management of COVID cases. So a little bit of introduction, that will be a brief one, some common symptom and diagnosis, and I will more concentrate on post-COVID symptom and ongoing symptoms that many patient is currently having or suffering and impacting their quality of life. So a bit of overview. So coronavirus and COVID-19, we called it SARS-CoV-2, and SARS is severe acute respiratory syndrome, and CoV was from COVID or coronavirus. Now, it is similar to other coronavirus, which you may have heard previously. There was MERS, there was SARS. That had happened before, and coronavirus is not something new. However, this variant was new in 2019, and it came from, or it first started within China. Now, this is a fancy picture where you could see it's an mRNA virus having multiple spike protein. This is just to give you overview. So initially when COVID pandemic started, cough, fever, breathlessness, fatigue, these are the common symptoms people or patient used to come in with. But it was very unpredictable, and any of you who have worked must have seen that within an hour patient could deteriorate very fast, and you have very little time to act, and therefore planning and understanding and initially was very challenging for all the clinicians who are working. This was a common symptoms that was reported and was published in BMJ. Similarly, when we looked at all the comorbidities, we found common comorbidities that all of you are aware, either respiratory or diabetes, obesity, or cardiac or liver. Now, little bit of letting you have a little bit of flavor about how the COVID pneumonia used to look like. It is like any pneumonia, but it was like a viral pneumonia. Therefore, the characteristic was primarily multi-lobar pneumonia. So it was not one lobe, but multiple lobes of the lungs were involved. It was more patchy. People were more hypoxic. It is more peripheral predominance. So you can see in this slide that in the peripheral part of the lung, both sides, it was consolidation. And when we looked at the CT scan, we found similar picture. You can see in the peripheries, and we call it crazy waving pattern in that scenario. Some specific was this reverse halo sign, which was quite common in COVID, and radiologists used to take that as a indication that is COVID, because not everybody was having PCR test positive, and many of them were diagnosed based on the radiological classical finding and clinical diagnosis. Fundamentals of care was primarily supportive, so people used to have hypoxia, We used to treat them with oxygen. There was something called conscious proning that came during pandemic more often. We learned out of what the ICU team used to do for other people, oxygen monitoring, and later on it came to dexamethasone and other antivirals that we have tried. And you may have heard recovery trial, which was very well known and widely published. So, as I mentioned, that patient who used to come in with COVID positive, they had ongoing symptoms, and fatigue was one of the commonest one that continued. It about 53% of people, they used to have fatigue, breathing problem, joint pain, chest pain, and worsening quality of life. It is mostly self-reported post-COVID symptom. So, little bit of definition. So after post-COVID, if it is acute, we class it within 4 weeks. If that was ongoing between 4 weeks to 12 weeks, that was ongoing symptom of COVID-19. But post-COVID-19 syndrome was classed after 12 weeks. So if somebody has symptoms still persisting after 12 weeks of having COVID infection, then that was classed as post-COVID-19 syndrome. It's nothing different to usual pneumonia, because if you remember, even the community-acquired pneumonia, we expect patient to get better in between 8 and 12 week time. So if somebody continued after that symptom, then that is after the COVID infection or the pneumonia infection. Now, you may be thinking that why I'm talking about COVID still, probably 4 years down the line. So what happened after COVID, that the burden of post-COVID or long COVID or post-COVID syndrome, all these terms are quite synonymous. That estimated 1.9 million people in UK alone, and that is about 3% of population, experiencing self-reported post-COVID symptom, and that is a ONS data from March 2023. So that's quite a lot actually, that 3% of your population having ongoing symptom. And what they found is the fatigue was the main, far more the most common symptom, and it was causing debilitation in many of the patients who had COVID in the past. It is very important to understand, in my experience and experience from other clinicians who looked after these patients, that these persisting symptoms are not always correlating with severity of the disease. So it's not that the people who are on ICU or they require ventilation, non-invasive, or long hospital admission, it's not essentially that they only have long-term problem. Even the people who are COVID positive and didn't require any hospital admission, they also presented or mentioned that they are having ongoing symptom. So severity of disease based on the X-ray or hospital admission is not per se was the cause of having long-term problem. Now, symptoms, as just mentioned before, four common symptoms that we are still seeing after COVID infection, and clinicians grouped that in one was the chronic fatigue, headache, and memory problem, respiratory syndrome that can be chest pain or breathlessness, chronic pain which is either in the joints or muscle ache, and the neurosensorial syndrome which has an accompanying altered sense, taste, and smell. So these four was widely presented by the patient in clinic. After COVID first round and second round, when we started seeing these patients in clinic, what we did is that we have to have more holistic approach in these patients. Like in any cases, when you see patient in outpatient, using the holistic person-centered approach is very important. And I always say to all my trainees that don't forget your history. That's the vital part. And if you have very good history, if you talk to patient, if you want to get the history individualized to that particular patient, then you know how to treat or how to manage that patient. Remember, as a clinician, not always we cure condition. What we do is one, to reassure patient, two, to support patient, three, to get more help for them to make their life easier to manage. I think that is the primary goal when we see patient after having this chronic condition. So history, appropriate examination, cognitive, psychological, psychiatric, all these and functional abilities, knowing about that is very important. And therefore, we developed post-COVID questionnaire, and we used that, and that was from the Leeds team who published it, and we widely used it to know about the various aspects of ongoing symptom patient was suffering. Now, in COVID, it was not a persistent or constant symptoms. What patient was saying is that it is more fluctuating. So one day, patient might feel fine, but the next day they were feeling extreme fatigue and unable to do any work. And that is always challenging and frustrating for patient as well as even for clinician to know what to do. So discussing with the patient experience and those symptoms and how that is impacting either their work or education or family life or personal life or their independency was quite vital. So this is all about assessment. So what I said in summary is mainly to take a holistic history and understanding the impact of ongoing symptoms after COVID in those individual patients, and to try and find out managing those symptoms by getting help either with the medication, but more than medication, it is multidisciplinary approach. So you may ask me that, what are the investigation you would propose or you did or has been useful? I have to admit that the investigations that we did is primarily that investigation you do for any of these patients who had pneumonia or post-pneumonia. So basic tests, the blood test is primarily to look at more inflammation. So when we talked about inflammation, you may have heard CRP, which is C-reactive protein. We checked ferritin. Because patient has other comorbidities, and we do know that COVID was multi-system inflammation, it has not only impacted or affected lungs, but also heart, muscle, your brain. So therefore, and the blood vessel, therefore we need to look at all these areas and various tests were around it. So the BNP was proposed to do because many people have got myocarditis due to the COVID infection. Because these patients are having fatigue, and therefore we shouldn't forget the common thing first. If we don't consider common causes such as diabetes and thyroid disease and other aspect why people can be fatigued or breathless, then we may misdiagnose or may miss the diagnosis. So tests were around history as well as considering other common conditions such as diabetes, hypothyroidism, or anemia or any other things. Now, most of these patients after COVID, when they presented, we advised them to do self-monitoring at home. And the self-monitoring at home was to know Do they desaturate when they work around or they walk? What happens to their heart rate? What happens to their blood pressure? Is that any correlation between change in these numbers and how they feel and how it impacts their day-to-day activities? So if I go back to the system point of view, that what other tests we have recommended or we did, if somebody is coming with breathlessness, we included breathing test, which is full lung function test, echocardiogram. We also included in some cases cardiopulmonary exercise testing, because that gives you a very good picture of either it's respiratory related or cardiac related, or it is deconditioning. So CPET or CPAX was very important to understand. Then you also consider psychological assessment. If somebody having memory problem, then the questionnaire for that. If somebody has GI problem or diarrhea, then you investigate their stool. You make sure that there is no infection, but as well as other conditions that may cause diarrhea as well. So broadly, investigations were quite broad, depending on your story and history of the patient, and any particular system that was more sort of involved. Other biomarkers which has come out of some studies and researches, ferritin is very common to be done, so yes, you can do, and that is one of the marker of acute inflammation. D-dimer is similar. D-dimer is also essential for blood clot, which we know that COVID patient had a high incidence of having blood clot. What was the particular cause is still not 100% convinced or sure, but people have two school of thoughts. Either it's inflammation or it is a thrombotic phenomenon because of hypercoagulability. Many of these patients was found to have vitamin D low, and there was some correlation with vitamin D and inflammation. Therefore, it's useful to check. And in some of the studies, they checked about inflammation, immunological marker like interleukin or TNF. But in common practice, when you see patient, I would not advise any of them. I would just advise you to do basic test, include ferritin. If the D-dimer is very high initially, then it's worth rechecking it. That has that gone back to normal. Vitamin D is another thing to do. And I think only these three I do and I recommend, including blood sugar. Now, so how would we plan, or what we are doing for these patients who are still presenting with symptoms? The first thing first is to understand the problem for that individual, and then advise them on self-management, and then option of supporting their self-management. We have pathways and also services around the country. Within Yorkshire, you have various secondary care and primary care. In Leeds, you have primary care COVID services in Leeds. You have same in Mid-York, so you have similar in the Calderdale and Huddersfield. So what we do that after assessment and doing basic tests, you refer that patient to that services. That services includes physiotherapist, nutrition therapy, sometimes there's occupational therapist as well. They look after those patients, they assess them quite in a holistic way and support them to manage. Specialist services can be also referred if you have any special particular symptom. If your patient has breathlessness, then, and if it is lung related, then you go to respiratory. If you feel that patient had myocarditis initially and has a high BNP, or symptoms are more consistent with cardiac origin, then you send to cardiology colleague to review it. Similarly, neurological condition or neurologist, you ask them to look after these patients. What is more important is that whatever decision you make, it's a shared decision-making process. So you work with your patient, you talk to them, and you try to support them based on the severity of the symptoms that they are talking. Now, I already talked about a little bit about management, and if I just revisit it, management is self-management, holistic management, talking to patient and finding out the option how to improve their quality of life. It can be physical, psychological, psychiatric, all aspects of management you need to consider. There are certain individualized plan you have to work on. If somebody is working, what type of work they do, is there any provision to do some adjustment in their work pattern? Similarly at home, what I found useful while looking after these patients for nearly 2 years after they had COVID is giving them a goal, asking them that, let's plan for next 3 months, then plan again for another 3 months, and get some help, join some self-help group, talking to the family members. What I personally found is that these patients, they got very worried really, and why not? I think it was very unknown. People were pushed into this unknown area, and when as a human, if we go in unknown area, we get more worried. So similarly happened to these patients, and they were really quite worried that whatever happened to them is that going to stay with them for long and whole life. And I can reassure you that 97%, as you have seen the data, got better, but that about 3%, they unfortunately continued having long-term problem. So when you see patient either in primary care or secondary care, what your approach should be is to, if you are in the primary care, then assessment initially with history, basic tests, and after that thinking about what is the predominant problem, and then either you send to the secondary care if you have any particular question to ask or any particular investigations that might help you. And if you feel that no, it's primarily patient needs therapist help, then you transfer the care to these services in community which has been arranged and commissioned. Don't forget, some of the patients, which when I met them, they said they were very keen to get involved in study and research. So just being aware that, what are the things going on, and just signpost them that if you want to get involved, then please contact the team, and if you will be eligible, they will contact you. So in conclusion, long COVID is a multi-systemic illness encompassing myalgic encephalomyelitis, or you may have heard chronic fatigue syndrome. Many patients had dysautonomia, impact on multiple organ system. It impacted vascular and clotting abnormalities. It has already debilitated millions of individuals worldwide, and still people are coming forward to say that their symptoms are still persisting. Diagnostic and treatment options are still insufficient. Many clinical trials are still ongoing and people are still looking into it. Primarily, they are looking at neuroinflammation, excessive blood clotting, and autoimmune related problem. So these work are already ongoing. Now, there is a review article came in Nature Microbiology in 13th of January 2023, which has very good reading. So if any of you interested, please go back and read this paper, quite detailed and very informative. Now I'm just going to give you a snapshot of what we do for in terms of fatigue, which I told you that is common or commonest symptom. If you take it as multifactorial, it's not one particular thing, and therefore you have to recognize, acknowledge, look for the factors, ask the patient to keep a diary, support, get support from the family and the professional, and asking them to pace their life as you do in chronic fatigue syndrome, and manage them in a supportive way. Similarly, the patient who has respiratory issues, I talked to you about CPET test, lung function test, chest x-ray, sometimes CT scan. Being a respiratory physician, if you ask me that, has this COVID caused lots of fibrosis? Answer is no, it hasn't. Most of these patients got better, and if out of 1,000 patients possibly I have seen, maybe 6 or 7 has very bad fibrosis, but those patients who are involved having multilobar pneumonia, ICU admission, they got ventilatory support. So barotrauma, as it happens to any pneumonia when you are in long term in ICU, is similar to that. So what you need to do for these patients is to keep an eye on them. Currently, they are not allowed to have antifibrotic treatment, or there is nothing in guideline that they would be given straight away. But recently, NICE has approved medication for progressive fibrosis. So if you keep an eye on them, and if their forced vital capacity comes down 10% about, then you may have discussion with your ILD team, and regionally they may consider providing them medicine, antifibrotic treatment. So from respiratory point of view, lung function test is important, chest x-ray important, HRCT can help you out to do that. And then keep an eye on it if it is fibrosis, to check that it's not progressive. In my experience, it doesn't progress. It either gets better or it stays the same. This is POTS, is postural orthostatic tachycardic syndrome. That is one thing which we found in some cases. And what patient was saying, that their heart rate goes very high. They feel dizzy. They sometimes feel when they walk that they are going to collapse or have syncope-like episode. Now, this condition, what we did in certain cases, I personally tried ivabradine and very small dose of beta blocker to help them. Some of them, they got benefit. I don't think all of them got benefit. And with time, they got better as well. But then non-pharmacological thing like giving them salt, fluid intake, making sure that they are not dropping blood pressure when they stand up. Those are the little bit of lifestyle changing can help. Then you have pain and discomfort. Again, usual bit, you either deal with medication or also without medicine. It was common in post-ICU, as it happens, that you develop neuropathy, physiotherapy and rehab helps you. Low-dose naltrexone is something given in trial phase. One of my patients asked me for this naltrexone, which has been used in chronic fatigue and ME. But when I talked to my rheumatology colleague, they said, not really, they would advise. So they advise that this can only be tried in a trial phase rather than giving to patient who has probably Googled it and found out that naltrexone can be given to them. Taste and smell, again, that was common. What I found is that most of them, they got better about 3 months to 6 months time. But again, reassurance and some training, and if anybody interested, you can go on the ENT website. They have this some tests to do, or some exercise to do, or training to do to get it better. Memory and concentration is another common thing. You may have heard that again, under a study, people have done scans of the brain to look at inflammation, look at that either that is causing ongoing inflammation after having COVID. The working with these patients are to advise them to pace their life, plan, prioritize, having diary to remember, and with time, that helps them. Low dose aripiprazole has been again trialed in some study, but not widely recommended yet. Now, some other things which you see in these patients, people are having diarrhea, probiotics can be tried. If they have blood clot problem or high D-dimer, blood thinners like DOAC can be used. Then if somebody has autonomic dysfunction, transcutaneous vagal stimulation was also advised. And people who has low immunity, intravenous immunoglobulin has been given as well. But I think I have to admit all these medicine that I've just talked about or intervention I talked about is coming out from the recent trials and recent studies, but not widely given to each and every individual. So bottom line is that you have to work with your patient, first of all, to have MDT approach, holistic approach, supporting them, helping them a non-pharmacological way. But if they are still struggling, then you can think about other medicines that have just come out of the various trials. I think that's all about, I have to say. I kept it in a way to give you a snapshot that what's happening after COVID. Happy to take any question. Nothing is silly, so feel free to ask.